Okay, hello everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we are going to talk about medications to treat agitation and dementia. I know we've heard from a lot of you struggling to find the right type of treatment for agitation with dementia. It can be a very, very hard thing to do. So with us today, I'm really happy to have two doctors who are experts in this field. We have Dr. Paula Rochon and Dr. Christina Reppas joining us. They are from Women's Age Labs from joining us from Toronto. Thanks very much for joining us.
Nice to be here.
Pleasure to be here.
Okay, let's just first start by talking about Benzos. What types of drugs? I mean, we're talking about a category of drugs like Valium, Ativan. Those are some of the brand names that people might be more Xanax familiar with. Can you tell us really what are these drugs designed to do?
Sure, I can take that question. So this class of drugs, which we call benzodiazepines, and you gave some very common examples. Thank you, Deborah. They're designed to essentially slow brain activity. And this is how they produce a drowsy effect, which is why they're sometimes used to treat conditions like insomnia or panic attacks. They essentially slow down brain activity. We'll get into some of the side effects later, but I do want to mention up front that the use of these drugs can become problematic because the brain does get used to that slowing down effect and that drowsy effect. It can lead to some drug dependence. And this is why they're listed as potentially inappropriate drugs to prescribe to older people, which again is something we can get into later. But in general, they slow down brain activity, which is how they work.
And isn't it true, Dr. Rochon, that they haven't really been tested on, I mean, there haven't been credible studies on the effects of people living in dementia, with dementia rather?
Well, I think in general, there's been an issue of the kinds of drugs that older people tend to use have not necessarily been tested on them in the way that we would like. You know, ideally, you want to make sure that if drugs are going to be used by a certain group of people in the population, that they were also included in those studies. And one of the issues that's been in place for quite a while is that it wasn't until a number of years ago that it was women that needed to be included in trials, for example, that were federally funded in the United States, and then not till just a couple of years ago that older adults also needed to be included in trials that were funded by federal agencies in the United States. And so you can imagine that older people, especially women, were not as perhaps represented as they should have been in these trials. And, as a result of that, for a series of different drugs, we don't always have them optimized the way we would like for that population. So that's been a bit of an ongoing challenge.
Do we know if actually women are more susceptible to side effects than men? Is there any type of research in terms of the side effects?
Well, one of the things that we do know, and then I'll hand it over to Dr. Reppas to talk about this, is in general, older people may be more susceptible, but women are particularly thought to be susceptible to adverse drug events. Dr. Reppas?
Yeah, so the reason that women, and particularly older women, are more susceptible relates to the differences in how drugs are broken down. And so women tend to metabolize or break down drugs differently than men. And as you get older, the way that you break drugs down also changes. And so because of that, some of the side effects or some of the byproducts of these drugs that build up end up having a stronger effect in women and in older people. So this is why we need to be particularly careful when prescribing drugs to these groups.
So I'm just wondering because, anyone who has a loved one with dementia experiences agitation. They experience it's part of the disease, very common. And I'm just wondering, are benzos, are these category of drugs probably the most commonly prescribed? Eh, this is a very unscientific way of doing this, but it feels like we hear about this classification of drugs quite often. Is there any feeling that either one of you have in terms of how often and how frequently they're being prescribed to treat dementia agitation? Either one of you.
Well, do you want to go? Go ahead.
Sure, I'll go. Yeah, I would say, and I think, again, this is from my practice, seeing as a geriatrician, right, seeing older adults that have dementia. I would say they're not the most frequently prescribed drugs. I know we hear about them a lot, but there are other drugs, I think, that are more frequently prescribed to treat some of the neuropsychiatric symptoms of dementia. So you mentioned agitation being one of them. But I think because benzodiazepines have many side effects, we hear about them a lot. But there are other drugs that are, I think, more commonly used, and typically benzodiazepines are not, they shouldn't be used first line, that's for sure.
What is the difference between, I mean, SSRIs, which are, I guess they're antidepressants. I'm not an expert on drugs, you guys will know more, but is there a big difference in terms, because we also hear of antidepressants being used all the time. How would you categorize or compare SSRIs to benzos?
Yeah, that's a great question, Deborah, and a question I think we get from families and caregivers all the time. So SSRIs, as you correctly said, are probably the most commonly used antidepressant to treat anxiety and depression across all age groups. They work by increasing serotonin in the brain, so they don't have the same drowsy effects that benzodiazepines have. And they can be useful in managing some of the agitation and paranoia in patients with dementia, because sometimes those behaviors are driven by an underlying mood disorder that either hasn't been diagnosed or is poorly verbalized. And so I would say that in general, these drugs are probably better tolerated. They also have better evidence. Dr. Rochon mentioned that there's not great evidence for any drugs really in the treatment of dementia, but the evidence that we do have points to SSRIs being well tolerated and having some benefit in reducing agitation and caregiver distress. So that's why we tend to prefer, if you're going to use a pharmacologic treatment, we tend to prefer those drugs over the benzodiazepines. And many of the societies and the criteria that list adverse drugs will also make that recommendation.
Yeah, maybe I think that's a very good point. There are pieces out there to guide clinicians in selecting medications. One of the guidance that people use is the Beers criteria, especially in the United States, which is a really an explicit list of medications that are potentially inappropriate for use in older adults. And drugs like, for example, the benzodiazepines are potentially inappropriate medications for use. So there are lists that give some guidance in that regard.
And so the benzodiazepine are under the not recommended for older adults?
Yeah, the category is potentially inappropriate medications. And so, these are drugs where, you want to think about other alternatives, and nothing is an absolute. You always, I think, when you think about things that are potentially inappropriate, there may be circumstances where, you working with the family, working with your clinician, it's decided that that's what you need to do. But for the vast majority of cases, they're considered to be potentially inappropriate.
We have a question coming in right now from Monica, and she's asking, she's saying she's a caregiver of her sister with intellectual disability and severe cognitive decline. She's been on clonazepam. Sorry, Pam. I'm terrible at
maybe it's clonazepam.
Clonazepam.
Yeah.
And I was
Mhm.
told to increase it for her aggression, but she has a flat effect all day, tired and still aggressive because I think she's tired from the meds. What are the natural alternatives? And I'm so glad you asked that. And then the other part she asks is there a happy pill out there? So one of the things that we want to do in this talk is to talk a little bit about alternatives. What are the alternatives to manage behaviors that people with cognitive decline are experiencing? And I think this is where two of you have a lot of expertise. So let's talk a little bit about, what strategies can people employ that aren't medications that haven't been tested for people with dementia?
Well, maybe I'll start, and then Dr. Reppas will certainly want to add in. But I think when you're starting to look at these problems, it's important to think about what are some of the non-drug strategies that you might want to take. I think that's what you're just alluding to, Deborah. So, for example, if a person is agitated, I think it's really important to step back and start by thinking, what is it that's causing this agitation? What is it in that person's environment or the circumstances that it is related to that agitation? And it's usually very, very individual. Like, I don't think there's one answer for what causes people to be agitated. It might be something related to a care routine, or it might be something related to noise or the environment or whatever it is. And often it's in discussions, in some cases with the patient, the person involved, but often their caregivers or family members, to sort of understand what those issues are, and then therefore, how might you address it? So, for example, maybe it's about the environment, maybe it's too loud, maybe it's noisy, maybe they do better in a sort of a quieter or calmer environment. Some people respond well to things, like some people may really, really like music. How could you bring that in as something that might be helpful? Some people are very attached to animals or like pets, can that have a calming effect? Or maybe it's about how people are approached, if it's around caregiving that's needed. Are there certain ways they like to be approached? Is there certain routines that work well? So it's very much, I think, about understanding what the issues are, working with everyone to sort of understand how you might tailor approaches. And I know there's also, go ahead.
No, sorry. I'm glad that you point this out, because my mom, who's in a later stage of Alzheimer's, has recently been looking for her parents, right? And if you say to her, oh no, your parents aren't here, she gets very agitated. But if you say, let's finish this first and then we're going to find your parents, then she calms down immediately, right? And so I always think of this strategy, it's like stepping into their world to, and a lot of people don't feel great about it because you're effectively lying and saying, oh yeah, your parents are, we're going to find you. But it really works. And
sometimes that's okay to do.
Yeah. Yeah. And sometimes we just have to be more forgiving of ourselves and use the best strategy to make the person calm down and less agitated, because in the end, that's better for them, right?
Yes.
Yeah. Yeah. And sometimes I think these things are not intuitive, and it's good for, like, there are specific programs that I like to refer caregivers to, like through the Alzheimer's Society, for example, where they can really learn, like, how do I respond to certain, requests or certain comments where, I don't know exactly how to respond, and it seems to escalate things. And so I think what the example that you gave was an excellent one in terms of teaching caregivers better coping strategies and better communication strategies. That's a really important step.
So what are, really, I guess the idea of like strategies is living for the moment, right? It's like, there's a lot of, as you pointed out, there's a lot of different reasons for agitation. Sometimes it's hallucination, right? And that's a tricky one because it's not real. And maybe you could say my mom looking for her parents is like a type of hallucination, but seeing things that aren't there, that's often something that we hear a lot about. Any recommendations for strategies there?
Yeah, that's definitely, I can take this one. That's definitely a tough one. At the beginning, I mentioned this group of symptoms called neuropsychiatric symptoms of dementia. So that includes things like wandering or restlessness, agitation is one, and hallucinations is also one. And that's a really tough one because it can be really distressing. And I think typically what we do is we want to sort of approach that in a very patient-centered way and understand whether it's distressing or not, because some hallucinations actually aren't distressing, and they can be redirected in the way that you mentioned, Deborah, about just sort of redirecting to something else, and they're not necessarily very distressing. But I think if they do become distressing, that's the point in time where it's important to talk to one's physician about thinking about some of the medications.
So I want to talk, I want to go back a little bit and talk a little bit about the side effects, because one concern is, are these drugs actually, because they haven't been tested on elderly populations and especially people with dementia, do we know if they can in fact be damaging to people? I mean, you know, what do we know, or what should we worry about when considering these types of medications?
Can I just clarify, are you asking about the benzodiazepines?
Yeah, oh, I'm sorry, yes, the benzodiazepines.
Okay. Sure, so I can take that one. So the main reason why benzodiazepines are listed as potentially inappropriate under some of those criteria that Dr. Rochon mentioned is because they increase side effects that in patients with dementia can be potentially quite serious and life-altering. So we know that there's an association with falls, and that's probably related to being lethargic the next day. And a fall can, as I'm sure most of the audience knows, can be quite a devastating event for an older person. It can lead to a hip fracture, for example, which can be life-altering. So benzodiazepines are associated with increased confusion. They're associated with falls. I mean, this is less important for dementia, but there's even been an association with new starts of benzodiazepines increasing car accidents. So, you know, the lethargy and the drowsiness that comes from these drugs does have significant side effects that has led for them to be on these lists of potentially inappropriate therapies.
What about?
I think it impacts any older person. I mean, these are things that impact people in general as well.
What about the addictiveness of them? Are they, you know, obviously, if medication is being administered, is there for a longer period of time, is there a risk of withdrawal symptoms? You had mentioned previously addiction. So I'm wondering, you know, are they like opioid drugs where it's really hard to get off of them? What do we know about that?
Yeah, absolutely. In that, there's a tolerance that occurs. They're not necessarily the same as opioids, but they do cause a tolerance in the brain that makes it very difficult if one has been on these medications long term to stop them suddenly. So people can go through some withdrawal effects, increased anxiety, insomnia. So because of this, actually, when we are counseling patients to come off of these drugs, we recommend doing it very, very slowly. And I think, in fact, Dr. Rochon, I don't know if you want to talk about the Empower brochures, but you know, we tend to follow like a very, very slow, like titration approach, where we decrease the drugs extremely slowly over long periods of time, so that our patients don't go through those withdrawal effects.
Yeah, I think this is something that's really important to think about. That if you're wanting to take people off of medications that they've been on for a period of time, like these in particular, it's important that you do it in consultation with your clinician or care provider. That also speaks to something we could talk about around, if you are wanting to optimize your medications for an older person, there's some really nice guidance that's out there that can help people think how to approach this, because I think this is a big question for everyone right now. People want to make sure they're on the right medications for them, and where meds aren't necessary, to think about the idea of deprescribing. So some of the work that we've been involved with has created, I think, a really nice algorithm that people can follow called drugs, which, that's kind of works well. But it starts with the idea of, it's really important to discuss the goals of care as the starting point. What is it that's important? What is it that matters? And that's something that really can vary from individual to individual. So the patient, the caregiver really need to have those discussions. And then you need to review the medications and look at what that person's on, because often they're not just on a single medication. Often there's a series of medications, sometimes prescribed, sometimes over the counter. So you really need to understand those. And then you need to think about these tools and frameworks. And we mentioned a couple, like, for example, the Beers criteria, the guidance that clinicians can use. There's another piece called Stop Start that is a similar kind of thing that's used in Europe and more broadly. And there's things that we've talked about related to things like prescribing cascades, but just to think if there's these meds fit any of these kind of lists of drugs where there might be potential concern. And then to think about the holistic approach, thinking about how this relates to the whole family or the whole individual in their particular situation. And then in some cases, medications are deemed to no longer be required and they need to be stopped. And in some cases, it's possible that some things need to be added. But I think it's very, very important, especially in the context we're talking about, where people maybe have dementia and they're on certain drugs, that those drugs are reviewed on a regular basis with the clinicians just to make sure, the combinations are right.
What is most commonly, like, for people, you said benzodiazepines aren't necessarily the first line of drugs that people are given. What is the most common? Do we know that? The reason why I think that's important information is people need to know what to ask about, right? Usually your doctor will prescribe something, and most of us don't understand what different medications do and what classifications they are. So I think it's important to understand what's most commonly used to treat agitation, or is it just really up to the doctor? Is there any protocol from the doctor's perspective? Try this classification first. If it's not working, go to this one. I'm wondering if you can enlighten us on how a doctor looks at this.
So maybe I'll start, and then Christina, you want to step in as well. So I think the first part is, when somebody's coming forward with symptoms, is you want to think about, potentially what are some of the causes, what might be contributing to this. And as we discussed earlier on, thinking about what some of the non-drug approaches might be. Or in some cases, it's also possible that some drugs that they're on may be causing, for example, agitation, and sort of looking at those and adjusting in that regard. I think it's really always important to start with the idea of thinking about the whole context before you jump in to start adding something new.
Did you want to add to that, Dr. Reppas?
No, I completely agree. I think you first, of course, need to ensure that a drug trial is necessary in the first place. And I think the decision about which drug to prescribe is often driven by the kind of agitation or behavior that we're talking about, right? Because agitation is a bit of an umbrella term, and it can encompass so many different things. And so, I would say selecting an appropriate drug therapy for the patient's specific symptoms is important. So if it's really distressing hallucinations, then one drug might be more appropriate than another. If it's something like wandering, we know that drugs are less likely to be successful and it's better to have environmental considerations about trying to reduce a behavior like wandering. So, I think it's really important to think about the behavior that you're trying to target, because there's not like a one drug fits all approach, that's for sure, and that's the case. I think in general we need to be patient-centered and think about the risks related to the behavior, and whether the behavior is actually going to be helped by some of these drugs.
Chris, who we know well, a member of our community, is asking, what are your thoughts on new Dexa for anger? It didn't work for me, but curious about your thoughts on that.
Is there a generic name for that? I don't know if I've heard of
maybe
that one.
That's the brand name. Yeah, I don't know what classification that is. It's NEUDEXTA. I don't know. We have to look it up. Maybe Katie could look it up while we're doing that to see what the classification is. But I do think you bring up a very important point, which is, it sounds like to me, there's not one way, right? It's really, and that's what's challenging, I think, for us. We don't know a lot about these medications and classifications. So you're really reliant on your doctor to say, try this. And of course, most people would just try it, right? Because we don't know a lot about drug classification, side effects, any of that. So I'm wondering if you could just, you mentioned that you've developed some of the materials, but give us like the cheat sheet of, one, okay, ask your doctor, is there strategies for this to treat I'm getting the feeling that you're saying go the non-medication way first if possible, and then the medication. Is that right?
I think that's entirely right. And I think, when you're going to your provider, your doctor, I think you want to start with a conversation. Here's the challenges that we have. How can we potentially approach it and look and discuss the various different options? I think it's so important to have those conversations. And I think it does have to start with what are some of the what we'll call the non-drug approaches that you can use, because you need to think about those irrespective. Those can make a lot of difference. So wherever possible, you need to figure out what some of the things are that are causing issues and how you can potentially manage those before you go into any conversation about drugs, or even if you are going to be thinking about drugs. So it's just really important to have those conversations and have those dialogues and to be in close touch.
I've heard a lot from people in our community saying, well, this one is okay. What I don't like is my loved one is quiet and sedate, but at least they're not, doing something that will harm themselves, or because they're in such a sedated state that they're just kind of existing, right? And I don't know. That's kind of a moral judgment there, but is that good for someone if they're kind of so medicated that they're kind of just existing and in like a, kind of just a trance almost? I've heard that a lot. Should we be concerned about that?
I think that, it's a hard question, because I think that it's important that you bring that up, Deborah, because I think you alluded to this in your question about a lot of what we do as geriatricians in treating patients with dementia it's informed by the values and preferences of that person and their caregivers. That's a really important tenet of our specialty. And when we don't have very good evidence necessarily from trials, I think it's up to us to give patients and families, some of the risks and benefits, but make our recommendations based on patient and family preferences. And I think depending on, certain behaviors, that might be more appropriate. And depending on other behaviors, that might be less appropriate. But I think in general, we always have to make sure that patient values and preferences inform our recommendations. And I think the other thing that's important to mention is that things should always be reassessed, right? So anytime we're starting a medication, it might have been, the appropriate thing to start at one point in time. But if caregivers are noticing more side effects, or even if they're not noticing more side effects, medication should always be reassessed at intervals, because they may no longer be needed as the dementia changes.
How often should we be doing that? Like every 3 months, 6 months? Like what's standard practice?
Well, you could set some times as to when meds should be reevaluated, but also when things change. If the person's circumstance changed, if a new medicine is being added, I think it's really important to go back and to look at what's already there. So it's important to do that at an ongoing basis.
Okay, so that medication we asked about, it was a combo. Everyone's chiming in. Thanks everyone for your research for us. It's a combo of dextromethorphan and quinidine. And for anger, and apparently it's Chris was saying that he took part in a clinical trial for rage with the medication. So do we know anything about that? Is that a newer?
Not certainly one that I'm familiar with.
You are?
No.
Yeah, dextromethorphan is the ingredient in some cough syrup. Yeah, that's right. So, but I think linked to quinidine, it's obviously not over the counter. And I mean, I think it's great that we have ongoing trials that are looking at these medications. But I don't think that's one that probably has the sort of evidence where we would be recommending it.
Yeah, and I mean, just to be clear with our audience, we're obviously not like, we're just trying to understand what different drugs do, and what we're not suggesting anyone should go and say, hey, I heard about this new drug, let's try it. We're definitely not prescriptive on this, but, I think it is a really important topic, and people need to know what to ask and what groups of drugs do so that they can make better decisions. And I'm guilty of not really understanding what medications my mom is taking and for what. I mean, I think I have an inherent trust of her doctor, but I'm sure he's not focused on whether she's been on this drug for 2 or 3 years, right? I mean, that's something that I think a care partner really needs to manage. But I guess I can ask this a different way. If it's working, then should we just stay on it?
Well, I think if it's working, that's good. But I still think it's important to go back and reevaluate, because sometimes maybe it's working, but maybe there's an opportunity to adjust a dose or something that you might want to do going forward, because circumstances can change. So I do think it's important to have sort of these ongoing discussions.
So I want to be able to give people the resource that you had mentioned earlier. You mentioned a couple of things, and Katie can look it up and link to it. But one of the things you mentioned was there is a classification of medications that are, more you should be concerned about for giving older people. Where do we find that information? What was the name of the resource that you mentioned?
So the things we're talking about are the different sort of frameworks and guidance that are out there around medications, and those are publicly available. You can find those in a variety of different sites. So we talked about one of the most widely known ones is called the Beers criteria. Another is the stop-start criteria.
Beers is BEERS, or how do you? Yeah.
Mm-hmm. We can send you those links as well. Okay. And then another one that we find is really useful that we've developed, Dr. Reppas and myself, as well as some colleagues, is one that's called a drugs approach that we've talked about in some of the work that we've done, which I think is helpful for family members to look at when they're thinking about, meeting with the physician and having discussions about what are the right combination of medications for the individual that they're caring for.
Okay, and just before we go, if you're going into the doctor's office, write the cheat sheet for us. What should we be asking our doctor for treating agitation symptoms? What are the first few questions we should be asking?
Well, I'll start and then I'll hand over to Dr. Reppas on that. But I think if you're coming in with a cheat sheet, I think you should also be coming in with a bag that has all of the medications that somebody's currently on. Because I think that is often something that, even the doctors are supposed to have that information. They don't always have it, especially over-the-counter type medicines. And I find it's also really important for our family and caregivers to have a note of when the medication was started and why it was started and who started it, because that information can get lost. And that can relate, further down the line to understanding side effects that you might not have anticipated. So I like people to come in with some of that basic information when they're walking into the office.
Dr. Reppas, would you want to add?
Yeah, no, I think that's an excellent start. I would just add other questions would be like, are the symptoms that I've described, are they likely to respond to these drugs? Because like I said, there are some symptoms that are more and less likely to respond. So I think that's an important question. Obviously asking about the side effects, asking about what side effects to look out for, and also what benefits to look out for, so that the next time you meet with your healthcare provider, physician, nurse practitioner, you know what you've been asked to look for, and then you can inform good decision making about whether or not the drug is working or whether the dose needs to be adjusted. So I think that's also really important.
Well, thank you so much to both of you, Dr. Rochon and Dr. Reppas. That's really helpful. It's a topic that comes up all the time. We'll link to your resources that you mentioned in the comment section of this video. Thanks very much for sharing. Is there a website too where we could keep abreast of your research? And hopefully more will focus on women, because that's so desperately needed.
Yes, we do have a website that focuses on Women's Age Lab and our focus on older women, and we can certainly provide that link to you as well.
Great. Thank you so much for joining us. And if any of you missed any of this interview, don't forget we post all of these interviews on our YouTube channel and on beingpatient.com. Sign up for our newsletter. That's when we tell you what is coming up in interviews like these. If you want to make a suggestion to us, feel free to email us at info@beingpatient.com. Thanks everyone for watching. We'll see you next time.
Thank you.